Good evening, everyone, and welcome to this, the latest in our series of continuing education programs on topics that meet the intersection of law, ethics, and healthcare. And tonight I am absolutely thrilled to bring you a conversation between myself and Frank T. Walsh, the acting Medicaid Inspector General. My name is David Hoffman. I am an assistant professor of bioethics at Columbia University in the bioethics master's and certificate program and a recovering hospital compliance officer. So we are going to get started with some background for those who are among the uninitiated who maybe happened into this webinar just by circumstance or because you need CLE credit. So we're going to be talking today about meeting patients where they are in enforcing the duty to provide quality care. Required legal notices, because there are always required legal notices. We are able to offer continuing legal education credit for this webinar, 1 hour of CLE credit in the area of professional practice. In order to obtain that credit, you need to watch the entire presentation, copy down the 2 participation codes that I will both show and verbalize during the course of the presentation, and then submit your course evaluation and course participation forms, which will be circulated at the end of the program. If you didn't get a chance to review the written materials that we prepared to support this educational activity, they can be accessed through the link in the chat box. And if during the course of the program you want to ask a particular question, either of me or Mr. Walsh, please feel free to put that in the Q&A box, and we will surely get to those at the end of the program. More required legal notices. Both Frank and I are here to have a conversation about topics that are subject to wide interpretation. So it should be clear that neither of us has any conflicts of interest to disclose on the one hand, but on the other hand, our opinions are merely our individual opinions and do not necessarily reflect the position of our respective institutions. Our agenda is to have a conversation about the element of the mandatory compliance program required under New York state law that obligates healthcare institutions of various stripes to engage in a compliance program that addresses a series of responsibilities and the application of those responsibilities to particular risk or program areas, and that will be our agenda for tonight. We're going to start with just a little bit of quick background for the uninitiated, and then Frank and I will start chatting. So when we talk about enforcing the duty to provide quality care, we're talking about a very specialized set of rules. And really, we need to think about how these rules should be followed in the context in which a hospital or other healthcare organization's compliance program is implemented. Spoiler alert, we're going to be talking about 521-1. That is the new 18 NYCRR, New York Code Rules and Regulations for the non-lawyers in the crowd, the new section of the social service regulations that both require and describe the elements of an effective compliance program. So when we talk about these rules and how we should go about following them, I can refine the entire body of these very detailed rules that exist in both statute and regulation with 3 simple rules of corporate compliance that will lead into our discussion tonight. And these are rules that I share with my students in my organizational ethics and compliance class at Columbia and with all of my clinician and administrator clients at hospitals that I have advised over the course of the last 40 years. So the first rule of healthcare compliance, don't bill for care that you didn't provide. That's stealing. Kind of obvious, and yet it goes on with great frequency because, as the bank robber Willie Sutton said when he was asked, "Why do you rob banks?" Well, his response was, "Because that's where the money is." And we know in healthcare compliance that there are people, often in the less scrupulous modes of medical practice, who see the Medicaid and Medicare programs as opportunities to cash in because there are so many dollars involved. So that's rule number one. Rule number two, don't bill for care that you provided, but that wasn't medically necessary. That's stealing. Right? If a patient comes in with a sore throat and you decide to do an x-ray of their leg, or perhaps more egregiously, an MRI and CAT scan of their leg for no medical indication, just so that you can bill for it, that's stealing. Don't do that. And then the third rule, which is the toughest and the one that brings us all together tonight, don't bill for care that you actually provided, that was medically necessary, but was of poor quality. That's what? Well, quality care never meant that the patient got all better. That would be guaranteeing an outcome, and no one is expected in medicine to guarantee an outcome. So providing poor quality care needs to mean something else. And then if those three rules weren't simple enough, here's my umbrella rule. And it's probably the most important rule for the purpose of the discussion that Frank and I are going to have tonight. Any problem, no matter how large, that the provider finds first and reports to OMIG is better than any problem, no matter how small, that OMIG finds first and that OMIG reports in the less friendly manner to the provider. Now that's good conceptually, but maybe hard for anyone who isn't in this line of work day in and day out to wrap their minds around. So I'm going to offer just two very general case studies, case models that'll make this more concrete for medicine. I warn you ahead of time, one is egregious and ought to send chills up everyone's spine, and the other is altogether mundane and common, but represents the bigger challenge for healthcare providers in fulfilling their obligation under 521-1 to operate an effective compliance program. So the first is the infamous Lebanon Home for Adults scandal of the early 2000s. This involved both egregious violation of the medical necessity rule and the quality of care rule, because this situation, which you can read about everywhere, just Google Lebanon Home for Adults, involved patients with mental illness who were residents in this facility being taken to a hospital right in the neighborhood for prostate surgery for no medical indication. And so obviously, if there is not a proper indication for a procedure to be performed and you perform it anyway, that is a violation of both the medical necessity requirement or obligation, and it is by definition not quality care, because it's care that's being provided that doesn't provide any benefit to the patient. That's the egregious case. The simpler case, and much more common, is the circumstance where a clinician, for example, orders non-pharmacologic treatment, that is something other than prescribing a drug, because the patient can't afford the medicine, and it would be poor care to give someone a prescription and send them on their way when the doctor knows that they're not going to fill the prescription because they can't afford it. and that they're therefore not going to get any benefit from that form of treatment. So the doctor orders a non-pharmacologic treatment, which may, in fact, not fulfill the highest standard of care because taking the appropriate medicine is the best way to treat the problem, but is appropriate for a given patient who finds themselves in the situation where they don't have access to the medication that would be the best form of care. So there's two case studies, two situations, one obvious and egregious, one far more subtle, which will be the focus of most of our conversation this evening. And let's pause now for those seeking CLE credit to acknowledge that the first participation code, write this down, don't forget it, is quality. And that brings us back to 521-1 and the requirements for an effective and beneficial and useful compliance program. And here we're talking about the basic bones of a compliance program, which is what Frank and his department are enforcing every day. And this is standard for every compliance program in New York, and in one way or another, standard for compliance programs across the country. It has to have a basic structure and rules for its compliance program. There have to be written contracts for implementing the compliance program. The institution has to have policies and procedures, defined responsibilities, meaning that there's someone, a compliance officer, who's in charge of operating the program, oversight of the compliance officer through a management level compliance committee, communication and transparency requirements, as well as training requirements so that people know how to do what they're obligated to do. And then there's the actual substance of where you have to apply these efforts. So 521-1.3 lays out the risk areas that every hospital, clearinghouse, insurance company, what we call payers, has to apply their compliance program to. And it starts with the obvious. And Frank, I'm going to be interested to hear your take on the order of these risk areas. But it's billing and payments, obviously. It's ordered services, meaning anything that is provided outside the organization, lab tests and radiology that gets sent out. And then in the middle, there are the two topics that we're concerned about, right? Medical necessity and quality of care, followed by governance, that's the operation of the institution, the obligation to provide reports, credentialing to make sure that the people providing care or providing services are qualified to do so, including contractors, subcontractors, etc. Number 10, Frank, not all of our favorite, but we know it's there. Other risk areas that are or should be reasonably identified by the provider through its organizational experience. And we'll be talking about what that means. And then some additional drill down that's unique to Medicaid managed care organizations. We won't get into those in detail tonight, but know that these are equally an obligation for managed care providers as they are for hospitals, other facilities, and of course, clinicians. So I'm going to stop sharing now and say good evening, Frank, and welcome and happy to have you here.
Good evening, and thank you, David, and glad to be here. And thanks to Columbia University for posting the session. Really happy to be here and to present on all aspects of our agency, and particularly on the compliance.
So I'm really happy to have this chance to talk to you because, I've been at this a long time and I'm well into the latter stages of my career. I don't have to worry so much. Other of my colleagues find you a little bit intimidating. We're hoping to disabuse them of that notion tonight. But It is in these areas of quality of care and medical necessity that I think there is the greatest measure of uncertainty, maybe confusion. So I'm just curious, where does this fit into your notion of what is an effective compliance program? And if you have any insight into why quality and medical necessity got shoved in the middle of the list, I'd be fascinated to hear that.
And I must admit, when I heard that question, I was I was struggling to sort of figure out whether there was any real purpose, and I would say there probably was not any purpose. Because I mean, I think that what we can all agree with is that medical necessity and quality of care should be near the top of the list. And I certainly wasn't any desire in our regulatory construct to give those two pieces a short shrift. And really, why it is as important as it is sort of given the independence of our agency and the fact that we don't specifically make the rules of the Medicaid program. We are, simply conducting oversight of the rules that are established by the Department of Health and other programmatic agencies that are involved. And kind of when I was thinking about this presentation today, I go back to sort of if you were to do the word count of all the rules and regulations and guidance that are provided, um, you know, most of those provisions are, the vast majority of them are dealing with the appropriateness of the care, that it's medically necessary and that it's delivered with quality and appropriate in an appropriate setting. And that's what you know that's what our intent is to review.
I have always considered the placement of medical necessity and quality of care as somewhat encouraging because it tells us that it wasn't sort of an afterthought, it wasn't tagged on. And of course, the fact that it comes after the big focus, billing and payment, suggests that it was something top of mind for whoever it was that drafted these regulations way back when, and that it fits in the entire continuum of responsibilities that organizations have. So, Frank, the first question that I have that I know all of my compliance and hospital council colleagues are most curious about is the definition of quality of care and medical necessity for purposes of us operating our compliance programs. And I fully understand that you were not responsible for the way these regulations were drafted. So I'll simply ask, how do you understand quality of care and medical necessity as elements or risk areas of effective compliance program?
I would answer that question. There is no standard definition, that's being applied. I think that it going back to, the regulatory and statutory construct, the rules of the program, that which is in the Medicaid, you know, pro- provider manual, that defines what meets the medical necessity and quality of care test for each specific service that's delivered. I think globally, I think we can say that medical necessity is that it's an appropriate service, it's rendered by an appropriate and qualified professional, that its scope is consistent with the scope of practice. It is kind of what we would expect to be good and appropriate care.
So I'm hoping that you're not seeing much of anything like the Lebanon Home for Adults kind of cases that I saw a lot more of back in the 80s and 90s. Can you describe what is sort of top of mind for you in the area of medical necessity, or in particular provision of medically not necessary or appropriate care? What sort of is your paradigm example?
I wish that I could say that we are not still seeing similar examples to the Leavenhome that you highlighted. I think they are fewer and far between. But as you said in your introductory remarks, where Medicaid and Medicare are providing, healthcare services, there are always a very small proportion of providers that are out there that have intent to do harm, and to take advantage of the program. And I wish I could say that there aren't new examples that I see on a fairly regular basis. But again, I go to, kind of at the most egregious level, where those are, the fraud and the stealing, all the way down to the least egregious level, which is, if something didn't, a signature wasn't on a medical record, and that we're reviewing, and so we could not establish whether it was medically appropriate or necessary because it didn't have the required signature.
And, the people joining us tonight need to understand, right, that signature is important to you because you need to have someone you can hold responsible for the judgment that that care was indicated. How do you deal with the sort of process issues that are embodied in the very complex way medical care is delivered now, electronic medical records? Later, we're going to talk about artificial intelligence and the challenges that that's going to pose. But what is your view of what hospitals could do better to make sure that we're fulfilling all of those documentation requirements?
Well, I would say specifically as it relates to the production of contemporaneous records. I mean, I think that the compliance offices, the clinicians, everyone sort of involved in the delivery of service, should be engaged. One of the points that I wanted to make here was, if everyone isn't involved, then no one's involved. These terms and enforce and ensuring that medical necessity is protected and quality of care delivered, is not the domain of purely the clinicians, and it is everyone in the operation to
Mhm.
sort of make sure. And the clinicians need to make sure that they are fulfilling their responsibilities, that they are meeting the requirements of the program, that the service is identified and rendered appropriately, and it's appropriate for that patient and that's accessed. And I think, on the compliance or the administrative side of the organization, it's sort of making sure that we can defend, that that indeed happened, and that we maintain the record. And not specifically in the compliance area, but all across the activities of our agency, the production of contemporaneous records is near the top finding, in just about every activity that we are involved in. And so I would encourage a focus on that activity, and it's in two areas. One, is related to the document being signed appropriately, and the other, as you mentioned, with the introduction of electronic health records, a lot of cases that we're sort of finding are lost or destroyed records because they didn't transfer over, or they're no longer 6 years down the road can the provider access those records, or the provider who is maintaining those records went out of business, and they didn't retain those records. So one of the takeaways for the audience is, as it relates to electronic health records and transitioning between health records, which is something that I know health systems are dealing with regularly. Is making sure that you're not losing something in that data exchange, that will help you defend yourself upon review or audit or investigation later.
For that critical 6-year look back period.
Because
So,
what we once thought was, just by dint of a natural disaster, we're seeing much, much more often, with the advent of this transition to electronic medical records.
and I have to say, having lived through now many of these transitions from paper records to a first generation EMR to system level multi-facility EMRs, the notion that someone says, oh yeah, this is all backed up somewhere. Are you seeing cases where the hospital or group medical practice, or for that matter, even a physician in solo or small group practice, goes into what was supposed to be the backup and finds, yeah, there are letters and numbers there, but no spaces between the words? And how do you deal with that?
Yes, we are seeing those examples, and just about every example that you could think of, we're experiencing, and it is, it's a real top of the mind, top of the line issue for, how do we deal with that, as we go forward. And I wish I had the answer, but we're still working our way through it. But I think that the point that I want to raise is that you need to know that you have full and complete access to that data. Because we are seeing, files that have been corrupted. Over time, we've seen examples where, there was a security key, and that key is either no longer functioning or can't be found. So it runs the gamut.
Creates an enormous amount of responsibility for the chief information officer and the maintenance of their relationship with the EMR vendors and all of the other data people that we deal with on a day-to-day basis, which leads us to the sort of bigger question. When we talk about quality of care determinations and care that maybe at first blush from the clinical documentation doesn't seem to be medically necessary, what is your attitude about sort of battles of the experts over a medical determination? How does the Inspector General's office approach differences of opinion about what is within the standard of care, what's within scope of care, especially in the situation that I described in my case number 2, where a clinician is engaging in something less than the best care possible because that's what the patient can access or afford? How do you approach that?
Well, first, we're not in the business of second guessing the the clinical judgment.
Mhm.
But we align ourselves. We have on our staff, medical professionals that are, that run parallel reviews and can speak to standard of care, and as to whether it is outside of the what the program parameters are. We're our auditors, our compliance officers, folks like that aren't, don't have the medical background, but we have staff that have the medical background that can make can make that judgment. Equally, we're relying on our programmatic agencies. So, I mean, where they have the expertise, their roles, and how they're going to apply how they would apply the rule, how they would see the situation, and that plays highly in our review as well.
Point well taken. Pause for a moment just to tell everyone, if you have a question that you would like for me to pose to Frank, you can put it in the question and answer box. And I quite assure you, we will maintain no records of who asks what questions. And I will take full responsibility and ownership for each question asked. So yeah, do feel free to jump in with any questions you have in the Q&A box. So, Frank, let's go back to that issue of the relationship between a compliance program, a compliance officer, compliance committee, and that exercise of medical judgment. It certainly is not lost on anyone that credentialing is one of the areas of focus, right? So, a compliance officer should be looking at whether the clinicians, and I use the term clinicians to describe broadly everyone who has contact with patients, physicians, nurses, nurse practitioners, PAs, therapists, everyone. When we talk about the credentialing responsibility and the prerogative of exercising judgment about what is appropriate and inappropriate care for a given patient under their circumstances, whether that's geography or economics or healthcare literacy. Any insights you can share from the cases that you've been looking at in your agency about how a compliance officer should relate to the credentialing process and the deference that clinicians are entitled to if they're exercising good medical judgment? How is that playing out in your compliance reviews?
Yeah, I go back to the rule that you established early on, with regard to providing quality of care. Where it's medically necessary, but not good quality of care. And I agree that, I mean, essentially, we're not making independent judgments. It's not the clinician's responsibility to ensure a positive outcome in every experience, that the patient doesn't normally get better. And within the Medicaid program, given how the services are organized and used, it is not mostly for restorative services. I mean, these are for for individuals that are kind of have long-term chronic care needs or end of life needs, that are primarily accessing services here. But when I look at that question, and from the perspective of a compliance officer, again, I'm not judging the clinical view of the clinician, but I am mindful of the trends, and that the experience is correct, and that, I mean, essentially, we're achieving a positive direction or a positive trend, not specific to an individual case. But I think the compliance office needs to be, it needs to understand pattern of services that are being delivered through their organization. And to the extent that you're seeing a track record that is not positive, you want to get to the bottom of it, because if I'm going to sort of say what the most common tool of the trade is for our perspective, is we're looking for those trends. We're seeing the data within the Medicaid program. We're seeing either excessive utilization, overutilization, inappropriate access to this service or that service, and that's what's kind of the first question, which is why are we seeing this trend? And I think to the extent that the compliance review is really sort of an extension of what the oversight that we're doing within the Medicaid program. I mean, they're auditing their organizations, they're identifying these trends, they're putting policies and procedures in place, conducting investigations. So they have all the same tools, and you want to find it first and root it out.
Indeed. And we have a question, in fact, from a physician. This individual identifies themselves as an anesthesiologist and asks, when they are part of the pre-op team, and part of the pre-op workup brief is that every surgery has to be reviewed to determine that what is being done is of good quality. What is an anesthesiologist's responsibility for assessing the quality of the surgical care going on at the other end of the table? Do you run into those sort of cross-specialty issues?
Um, I would say that we run into those special, but not specifically, not often. I think that is something that would more be kind of part of the policies and procedures of the given institution. That that essentially what we want to make sure of is that the full care team is providing appropriate services and coordinating, and exchanging, and communicating, for lack of a better word, about the appropriateness of the services delivered for the full case.
I think what this anesthesiologist is getting at is that she or he can't judge the surgical actions of the surgeon, whether they move their hand like this versus like this. But from what you said earlier, I'm guessing you're going back to the documentation and looking at things that an anesthesiologist, for example, should have known because they could have known. And it sounds like it's going to be the more obvious and egregious circumstances where an anesthesiologist ought to be aware that the patient didn't have the physical limitation that the surgery was being performed for. I'm taking my mind back to the Lebin case.
Yeah, no, I would, I would echo that we're not questioning the judgment, but we're looking to ensure that the practice, within the scope of practice, within what the given clinician is responsible for, or should be responsible for, was applied directly.
I think what we hope that all of the participants in today's webinar come away from is that you don't expect clinicians to know things that they can't know. right? That there is a record of what information was available to them, and that's what they should be directing their concern to. Is that about right?
That is absolutely right. And the case record is the primary document.
And made more complicated because electronic medical records, nobody actually even knows how long the record is. They don't have page numbers. They have fields within fields within fields, which is one of the big challenges that compliance officers face is, what is the record that is subject to scrutiny? The next question kind of focuses in on that from the perspective of the clinician who reports something. So this individual asks, what recourse does a clinician have if they report poor quality or egregious care by another provider and gets fired for doing so? Especially uh, where it states that employers have more rights and can terminate contracts without cause. So I guess this is the question about how much is a clinician expected to put themselves at risk in order to fulfill their obligation to speak up, to report out, and to make sure that deficient care doesn't go left unacknowledged. How do you approach your whistleblowers and your confidential sources of information? Anything that you're in a position to share with the audience?
No, what I would say is that essentially we look to sort of we look for that information, we look for that engagement, and we try to protect the confidentiality and um, you know all the rights that are out there, with regard to ensuring that our investigations and audits and reviews um, move forward. So a bit of that is kind of outside our normal parameters. But we would protect the identity and you know protect the relationship. Um,
Making the important point that every compliance program, even though it's not its own element of the compliance program anymore, what used to be element number 8 now has been folded into the first 7. The duty for the compliance program to have a mechanism for confidential and anonymous reporting of compliance situations.
yeah.
And are you seeing growth in anonymous reports of concerns, or is that pretty much the way it's always been?
Um, I think not that we're pretty early on into kind of those requirements. So I'm sure that we're seeing it, but it was one of the areas of particular focus that we wanted to make sure that there was ability to report, so that these circumstances could become made aware of and addressed, without ramifications, professional or otherwise, down the road.
My feeling, having spent my entire adult life working in hospitals in various administrative roles, is that hospitals aren't taking advantage enough of the ability of employees to report things through the compliance anonymous reporting process or the confidential reporting process where clinicians don't feel like there's a way of reporting it up through their own chain of command. And I think that's what this participant is getting at. There are safer ways from a preservation of employment perspective to raise concerns, which, we should highlight, don't need to be a conclusion that somebody's doing something bad or wrong or medically not necessary. That's not anyone's responsibility other than the compliance officer to conduct that investigation. But I think everyone participating tonight can take away from our discussion that reporting up through the compliance program is probably the safest way of bringing something to OMIG's attention. Does that seem fair?
Yeah, no, I think that that's really fair, and it was kind of one of the guiding principles behind our changes in 521 to really integrate and to provide authority and strength behind the compliance aspect, that kind of they're synced in with the management operations, and that they have the ability to address the bad behavior, for lack of a better
Mhm.
phrase, um, to sort of prevent issues from arising.
So the next question is fascinating, and the person who posted it framed it in terms of private insurance, commercial insurance. But I think we could easily address the same subject from the perspective of Medicaid managed care, because from the reimbursement perspective, it operates for a healthcare provider organization in much the same way. So the questioner asks, I frequently encounter in the private insurance world providers who prescribe medically necessary care only to have the facility, so that would be the institution, cave to an insurer's determination of lack of medical necessity to discharge patients from the hospital, rehab facilities, and the like, against the patient's wishes and the provider's judgment. To what extent do you examine similar scenarios in the Medicaid context? And if you do, how do you avoid second guessing someone, the clinician's medical judgment, which I think is square on a question about the managed care program. So you have a take on that?
So yes, I think that essentially what we're looking at with regard to our contracted managed care entities is that they are not doing anything that is inhibiting access,
Mhm.
to care for these recipients. I mean, that we're we're providing and paying for, through a capitation, a comprehensive medical benefit, and whatever that recipient is requires, the the health plan is supposed to provide. And to the extent that they are inappropriately imposing prior authorization requirements or any other requirements, that's something that we're looking at very closely. Because the ultimate you know objective is that the recipient is receiving the care that they need, as it has been determined to be needed.
We talk in the law about justice delayed being justice denied, and of course, the same is true for medical care. What does OMIG want to see from the provider community and from the managed care community about reports of instances where decisions are being delayed beyond what could be considered reasonable? Is that something that you want to hear about from providers?
I think that's something that both we and the Department of Health want to hear from providers. I mean, we hear it anecdotally, from recipients and providers alike. But the more the more we hear it, the more a trend can be identified. We can deal with that, or deal with that plan. I mean, it is not an unusual circumstance to receive information that a plan is, restricting service delivery in some fashion, and that becomes known, and the Department of Health is reaching out to say that's not what you should be doing. So I would say yes, it's something that we want to hear, because we want to hear it and address it as quickly as we can.
It is a reality that is no one's fault. Doctors, lawyers, accountants, architects have an inherent divided interest in their own financial livelihood and providing all of the necessary service and nothing more. But that tension is amplified almost beyond recognition when you talk about a managed care program involving public dollars, because there is an inescapable, and it's nobody's fault, financial incentive to scrutinize medical necessity in a situation where the patient really has no leverage, has no way of bringing that in a timely manner to conclusion. Is there any advice that you can give to, for example, patient advocates and care managers about how to protect patients' need for timely care in a Medicare or Medicaid managed care environment?
Yeah, and I think that is why we put as much emphasis into compliance and to sort of oversight of our healthcare programs. Because I mean, a lot of these requirements that health plans and others are putting into place are to get at that very small percentage um, of recipients or providers who are taking advantage of the system, and um, you know um, removing dollars from the system. So, I mean, I think it is incumbent upon all of us to identify that essentially we have controls in place, as well, to ensure that the patients are receiving the care that they need in an appropriate and an efficient manner, and we are providing precisely the amount of public dollars that are necessary in order to deliver those services. So the more we can make that case and allay the concerns on the from the payer side, and I add the state on a fee for service side. We're a payer too. The more we do our work, the better we do our work, the more we're in control. The less likely we run into these concerns. I mean, there's always the natural financial conflict, that you're receiving a capitation, and if you can deliver the service at less than that amount, there's benefit. But the intention is that benefit's paying for the next recipient that is in your plan,
Right.
that has a need that it's above the average. So
Yeah, let me put 521-1.3 back up on the screen, because we started our conversation with tonight's focus on medical necessity and quality of care. But if you turn the page, literally and figuratively, to the second half of 1.3, the detail that was built into the revisions to 521 about many managed care organization really do speak to exactly what you were just discussing, right? We have the requirement of complying with the terms of the contract. We have requirements for submission of encounter data to the health department, the network adequacy That is the number and type of clinicians that are made available to patients, subcontractors, underutilization, again, repeating in the managed care context, provision of medically necessary services, not providing too many services, but providing too few, and then the processing of all of these claims so that people get what the state is paying for. I don't think number 11 in 521-1.3 gets the attention it needs. And I think we would all benefit from being more attentive to the terms of those contracts. I've seen just in the last couple of years with the compliance reviews that compliance with the terms of contracts is something that we are all spending a lot more effort on.
Yes.
Do you
And
think? Go ahead, I'm sorry.
yeah, no, yeah, yes, and I think that this was a thoughtful act. When we posed the 521 revisions to apply those provisions or to enhance the compliance provisions that the plans have to be operating similar to the providers and the state.
So let's take a quick pause for the second participation code since we're coming up on our hour. The second participation code is necessity. How could it not be? And Frank, in the last few minutes that we have, I just want to acknowledge two topics. One, long-term care. Last time I checked nationally, long-term care accounted for about 2/3 of Medicaid dollars. I don't remember the stat for New York recently, but long-term care obviously is the opposite dynamic from a compliance perspective of acute care because, like capitation, um, the state, either directly through indemnity plans or managed care plans, are paying for a residential care environment that meets standards of care. Um, are we doing what we need to on the provider side to make sure that patients who come from long-term care settings, whether it's nursing homes or assisted living, independent living, that we are accounting for what is expected? How do you expect a long-term care provider to demonstrate that they are providing what meets the standard of care for that kind of facility?
Yes, and I think that essentially that is kind of the flexibility that we have built into our compliance requirements. That I mean, essentially every compliance program is intended to kind of address the care standards, the relevant risks that they see for the delivery of services in that setting. So,
Mhm.
when we're reviewing a long-term care facility or a community-based long-term care facility, we're not anticipating that they will have a compliance program that is alike or has the same features of a provider in acute care setting. We would expect them to have differing requirements, differing risks that they're dealing with, and the ability to address those, similar to how they're being addressed on the acute care side.
Very important observation. Let me close out with a question for which I think there's no answer, but we should at least acknowledge it. Has OMIG started thinking about how artificial intelligence is going to influence medical decision making about quality of care and medical necessity, and how you're going to deal with your enforcement responsibilities in an environment where algorithms of all different types, generative, static, decision support, decision substitution. Have you thought about how you're going to manage that?
Well, yes, we have thought about it. Have we concluded anything? No. I think that there's no question that the addition of technology, will provide greater efficiency. But the piece that we're concerned with, and much with sort of technological improvements all throughout the healthcare industry over time, is that we understand the good and the bad.
Mhm.
And I think something to sort of throw out to the compliance community is that essentially we really have to have a conversation about as we are improving the efficiency within the program, that we're not giving up anything in exchange that helps us maintain the 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 compliance structure that we already have in place. The thing that keeps me up at night is the application of AI to make everything the same, when I recognize that differences in a patient experience, differences in a patient's demographics, their treatment, is how I identify what's right and what's wrong. As
Mhm.
it becomes, you know, you can't develop a comparison, then I begin to question whether it's appropriate,
Mhm.
down the path. I'm, one of the clearest examples of fraud that's going on into the program is when you see the same documentation over and over and over again, with no changes at all. Um, and that is something that we're very engaged and concerned about. But there are also tremendous advantages that we're looking forward to using it in terms of data access. But we're very early in our process and going through the state process, with regard to the application of AI.
Well, Frank, I look forward to having those conversations with you. I think they're going to be fascinating from a medical ethics perspective. AI has the potential to do enormously positive things and also is filled with risk of unintended consequences. So I think that will be our discussion down the road. I want to thank you. I think this has been an enormously valuable conversation. I learned a lot. I hope our audience did, and I hope we will have future opportunities to engage with your office because heaven knows nothing in healthcare ever stays the same.
Absolutely, it's been great, and we offer that to the extent that there are questions that go beyond this session. We're here. You can and reach us through our website, obig.ny.gov, and all of our contact information is there, and we're more than happy to engage.
Looking forward to it. Well, thank you again, Frank. I really appreciate it. And to our audience, if you find this kind of discussion interesting, the Columbia Bioethics Program has these kinds of programs frequently. We have two coming up, one with a colleague and one of my former teachers, Tia Powell, in conversation with Barbara Rothschild. Uh, it's an ethics for lunch, free lunch. What Bad Cases Teach Us. And that'll be up at the Medical Center on Thursday, October 30th. And then on November 13th, I'm doing another program looking at an AI issue, automation complacency, and how AI induced abdication of medical decision making is something that can happen if we are not on our guards. So I invite all of you to join us for those programs and everything else that you can find on our program website for the Columbia University School of Professional Studies Master's and Certificate Program in Bioethics. Just Google Bioethics Columbia events and they'll all pop up. Thank you again, Frank, and good night to everyone.